which we celebrate the diversity of our workforce and the communities and the patients that we serve. Now, each year, LGBT History Month has a theme, and this year's theme is Body, Mind and Soul. So we're delighted to invite our guest speaker this evening to discuss LGBT plus and health, as well as perhaps mind and soul. And we will see where you take us on that subject, Michael. So turning to our speaker, who is putting us all to shame with a tie and a jacket, and probably almost definitely trousers this evening. So Dr. Brady, appointed to the National Advisor for LGBT Health at NHS England in April 2019. What a time to join this national role. You work across the NHS England and NHS Improvement within the Government Equalities Office and a wide range of stakeholders, partner organisations and the LGBT community to address health inequalities for individuals and communities and improve experience in the NHS. Michael, you're also, if that isn't enough, an HIV and sexual health consultant at King's College Hospital and the medical director of the Terence Higgins Trust. And I hope you feel able to draw upon all of those roles in talking to us tonight on this topic. So the idea is that Michael will talk to us for about 30 or 40 minutes. He's got some slides to share with us, so we'll put those on the screen. There will be time for questions and reflections and points and observations. And I think we're requesting, Katrina and Monica, for those to be put into the chat on Zoom or Facebook. Is that right? Both of those tools will get through to us and we'll find a time to engage with those questions at a later stage in this session. So please do just throw your thoughts in and we'll see where that takes us later in our conversation. We will be streaming this live, but also recording it for our website as well. So do bear that in mind. I think that was my any technical additions I need to add, Katrina or Monica. Are we happy to go? Should we hand over to our main event? Michael, please, over to you. Thank you very much indeed for joining us this evening.
Thank you very much, David. Thank you for the introduction and the invitation to come and talk to you tonight. It's a real pleasure to be able to join you in LGBT History Month. I'm feeling slightly overdressed, but there you go. So yes, I do have some slides. Hopefully I can make the technology work and share my screen. I'm hoping that that's working. I'm hoping somebody will shout at me if it's not. So just there we go, brief summary of what I'm going to cover. Hopefully there'll be plenty in here. It's very whistle-stop tour, but plenty to stimulate some thought and discussion and questions at the end. I'm going to do a bit of an introduction to LGBT health inequalities because the focus is on body, mind and soul. I'm going to say a little bit more about mental health than some other conditions. We can't talk about equality, diversity, inclusion in any sense without mentioning COVID. So a few thoughts, reflections, and a bit of data around the impact of COVID-19 and the lockdown on LGBT plus communities. And then tell you a little bit more about my role and my priorities, what myself and the team are working on in NHS England. And I want to, by way of a little bit of a plug, say something about Rainbow Badge projects and phase 2 of the Rainbow Badge project, which we're working on at the moment. So I always start these talks with a bit of a step back before we get into the health inequalities and talk about context. It's true to say that we have made significant progress towards better LGBT plus equality in this country. But it is fair to say that still LGBT people face considerable barriers to leading happy, healthy and fulfilling lives. LGBT people still face unacceptable levels of discrimination, bullying, harassment in the street, at school, sometimes in their own homes, in the workplace, in healthcare, unfortunately. And when thinking about this context, it's important to remember that this lived experience, these aggressions or microaggressions are experienced by our colleagues and staff as well. So the NHS workforce is no different in terms of how it experienced this sometimes very toxic or hostile environment. And then when thinking about health specifically, in this context. LGBT plus people face greater inequalities pretty much across the board. It's really very hard, if impossible, to find any data or evidence to show where LGBT plus people fare better in terms of their healthcare. Pretty much across the board, they score worse in terms of their experience, report poorer access to services, have poorer satisfaction, and frequently have worse clinical outcomes when compared to their heterosexual or cisgendered peers. And as I'm going to say shortly, this is certainly being exacerbated by COVID-19, as has the experience, obviously, of other marginalised or disadvantaged groups. The other thing of context that I want us to keep in mind when we're thinking about this is the concept of intersectionality. Now, we are none of us walking around with one single protected characteristic or one single experience or coming from one single group. We're all an amazing and rich and diverse mixture of our upbringings, our education, our age, our ethnicity, our sex, our gender, our sexual orientation, our religion, whether or not we are living with a disability. And it's the intersectionality of all of these intermingling characteristics and experiences that we need to remember, because it is this combination that combines both to create the discrimination and inequalities that people experience, but also the privilege that some of us have as well, which impacts on that relationship. And so it's important in this area, and I think in all areas of equality and diversity and inclusion, that we ensure we move towards having a better understanding of how that relationship between these characteristics works and how it impacts on marginalised communities, and make sure that when we're thinking about one group or putting our efforts to addressing inequalities in one group, it's not at the expense of other groups, and we're thinking about those complex interrelations of characteristics. And it's also important to remember that we use LGBT or LGBT plus or LGBTQ plus as umbrella terms. There's a huge amount of diversity within that, obviously, as it covers a range of sexual orientations and gender identities. So that diversity within the LGBT plus group we need to keep in mind as well. So this is my kind of wheel of inequalities. When I started this job nearly 2 years ago, there were, I think, half a dozen on this wheel. It's growing all the time as we find more evidence. I think there's 13 or 14 there. I'm not going to go through these in great detail. I've got a few slides to pull out a few key points. But essentially, the take-home message about this is, wherever you look for it, and if you do look for it, you find inequalities of experience, of outcome, pretty much everywhere. I'm going to talk specifically, or have a little bit more detail about mental health. That's purposely at the top of this wheel in red, because we have more data there, and it's probably the single area where there are the greatest inequalities within the LGBT plus community. So just a few bits of stats. The Stonewall Health Report, if you haven't looked at it, it's not very long and a really interesting read. Perhaps a little old, but I don't think much has changed since 2018. 5,000 respondents to this survey, really high rates of depression, more than 50% anxiety reported in the last year. So this is recent experience of depression and anxiety. And you can see there they have a little data on this intersectionality concept. So 52% report depression in the last year, but you see higher rates in younger LGBT people, in LGBT people from Black, Asian and minority ethnic groups, or LGBT people from lower income groups. 1 in 5 aren't out to anyone about their sexual orientation when seeking general medical care. So there's a challenge there in terms of how we can best meet their needs if people are not confident and comfortable disclosing their sexual orientation. 1 in 4 LGBT people reported experiencing a lack of understanding of specific lesbian, gay and bisexual health needs from healthcare staff. And again, we can see those rates going up when we think about intersectionality. 1 in 3 for BAME LGBT people, and similar higher rates for LGBT people with a disability. And 1 in 7 in this survey, and that's a similar rate to has been reported in other surveys, reported avoiding treatment, actively not going there or delaying going to treatment for fear of discrimination because they were LGBT. I put this slide up as well just to make the point that these mental health problems are deeply ingrained and very evident from a very early age. This is a slide from a study from Bristol University, which is a cohort study following a large group of children and young people up through different ages. It doesn't just look at mental health, but it asks a range of questions in serial questionnaires at different age groups. And there you can see those different age groups and the time points on the graph. When the children in the cohort reached the age of 16, they asked them then about their sexual orientation, not when they were younger, but at each of the stages, they'd all done what's called a short moods and feeling questionnaire, which is a validated questionnaire in children and young people about mental health, depression and anxiety. And you can see that our higher score means worse rates of mental health problems. And the striking thing there is that you can see those differences in children as young as 10, and that those differences get larger, so much higher rates of mental health problems reported as they move through adolescence, and so certainly when compared to their heterosexual peers. Just a few other thoughts on some other areas. This is not exhaustive. Cervical screening and other screening is much worse in people from LGBT communities. Lesbian or bisexual women are much less likely to have had a smear. And often that's about misinformation about cervical cancer. They've been told by healthcare professionals that because they are gay or bisexual, they have lower rates or are not likely to get cervical cancer. And obviously for trans men, cervical screening can often be, there can be many barriers and blocks to cervical screening when those services are delivered in settings which are very focused towards cis women. My particular area of sexual health and HIV, lots of inequalities, gay men experiencing much higher rates of infections like syphilis and gonorrhea. We know that young bisexual women are much more likely to have poor sexual health when compared to heterosexual women, so higher rates of chlamydia or unplanned pregnancies. Obviously, gay bisexual men much more disproportionately affected by HIV. Globally, trans women are nearly 50 times more likely to be infected with HIV, with an average global prevalence of 20%, so really high. Those figures are not reflected in the UK, where HIV rates in trans populations are not as bad as other countries. Chronic diseases, we have a little bit of data, but not very much, and that's probably because we don't routinely collect data in these clinical settings, or don't include sexual minority or gender variance as sort of demographics in clinical research. So the inequalities of experience, frequently in surveys we see lesbian, gay, bisexual people reporting poorer communication with healthcare staff, often rooted in assumptions about heterosexuality or even overt discrimination. And trans and non-binary people have particularly poor experience, and much worse than those who are lesbian, gay and bisexual, driven by language which is poor, gendered materials such as leaflets, for example, aimed at women but given to trans men, so for example in maternity settings or cervical screening, very gendered spaces such as maternity units, and even just simple things like IT systems which cannot record their gender, which all kind of culminates, certainly for trans people, of feeling excluded, that they don't have the relevant information, advice or services, and either are or have an expectation of being treated badly or differently when accessing services. So as I said, we can't talk about inequalities without talking about COVID. I think I've just got one more slide on COVID, just in the interest of time, but I would, if you're interested, refer you to two of these surveys, one of which I'm going to talk about, the one on the right, which is the Outlife survey undertaken by LGBT Hero, just because that's the largest of the surveys that we have on the impact of COVID, with 2,300 responses. Also really good surveys, the Hidden Figures report from LGBT Foundation, with I think about 500 respondents in that. And similar to other marginalized or disadvantaged groups or minority groups, we're seeing COVID-19 highlighting and exacerbating existing health inequalities. So worsening mental health, worsening senses of isolation, people being forced to stay in LGBT-phobic environments or homes which they wouldn't normally stay if we weren't in a pandemic or a lockdown, poorer access to services, greater rates or reported rates of domestic abuse, substance misuse, and homelessness. And we're a long way from coming out the other end of COVID, and I suspect that services may never feel back to normal or completely the same as they were before. So we need to bear this in mind and do more to think about our recovery and address and our how we address inequalities kind of through this COVID or post-COVID lens. So just one slide, just to really just to pick back up on this sort of mind and soul theme, particularly around mental health. So the Outlife survey is, say, the largest survey of its kind, with 2,300 responses, done in the early part of, or the early mid part of the first lockdown, where nearly 4 in 5 LGBT plus people said their mental health had been negatively impacted by the lockdown. Quite high rates of depression and anxiety before lockdown happened. So 24% said they were depressed very often or every day before lockdown, and this grew to 43% during the lockdown. Similarly, about 1 in 3 LGBT plus people said they would experience anxiety very often or every day before the lockdown, and that increased to 50% during the lockdown. And then thinking about young people, so that intersectionality between age and sexual orientation and gender identity, before lockdown, about 1 in 5 LGBT people said they experienced loneliness very often or every day. During lockdown, that had more than doubled to 56%, and much higher rates in younger LGBT people, those under the age of 18, more than 2/3 felt lonely very often or every day during the lockdown. So considerable impact on mental health, and there's similar data for some of the other issues that I mentioned. Now, I'm mostly talking about patients and service users, but I wanted to say a couple of things over the next 2 or 3 slides about our NHS staff, our workforce. Now, this is some data from the staff survey, which does ask about sexual orientation. It doesn't currently ask specifically about gender identity or trans status, although we're changing that. So we have data for people who are gay women, gay men, bisexual. And this looks at the 10 domains on the NHS staff survey, and the blue bar is the heterosexual population, which obviously is the majority of nearly 500,000 of the respondents. And the other colours are gay women, bisexual men, gay men, and those that identified as other, or those that said I would prefer not to say. And the take-home message from this is that 9 out of 10 of those domains, gay women, bisexuals, gay men, or other, or I would prefer not to say, all reported worse experiences when compared to their heterosexual colleagues. And in more detail, you see higher rates of reports of bullying, harassment, or discrimination, for example. And that is where people are asked about have they experienced it from patients or service users. So again, gay men, gay women, bisexual people, those who say other, or those who say I would prefer not to say, have report higher rates of bullying or discrimination or harassment from patients and service users when compared to their heterosexual colleagues, which is the bar on the left-hand side. And we see the same response if they're asked if they've experienced that from managers, and we see the same kind of response if they've experienced that from other colleagues. So we have a lot to do for our staff, just as much as we have to do for our patients and service users. So just to move on to a little bit about what me and my team are focusing on at NHS England. Broadly, what we do fits into these 4 key priority areas: monitoring and data collection, training and workforce development, delivering more LGBT inclusive services, and supporting LGBT staff and ensuring the workplace is inclusive. And I'm just going to go through, I've got 1 slide on each of these topics. So collecting data on sexual orientation and gender identity and trans status is essential. I mentioned already that our data collection is relatively poor and patchy, and well, there's many reasons why it's important, if not the fact that we have, I would say, a statutory duty to do this. So sexual orientation and gender reassignment, or being trans, are 2 of the 9 protected characteristics in the Equality Act, and we have a legal duty, and as public sector organisations under the public sector equality duty specifically, we have a legal duty to pay due regard to lesbian, gay, bisexual and trans people, and to be able to actively demonstrate that we're not discriminating against them based on their sexual orientation or gender identity. And I'd suggest that we're not able to do that robustly unless we really know how many of our patients and service users are from these groups, and how many of our staff are from these groups as well. So we need to ask the questions as the starting point. I don't know who said this, but it's a great quote. It says it all. Otherwise, I would reference them. But if you don't count us, we don't count. Kind of summarizes why this is important. It's essential, as I said, for us to understand the range and the depth of the inequalities and the poor experience. It's essential that we collect data and measure it. And also, we can't make any active measurements of the impact of any of our interventions unless we've got good data to underpin that. We have a national standard for sexual orientation monitoring. We don't have anything similar yet around gender identity and trans status. And those questions have been rolled out in patient and staff experience surveys. For example, as I showed you the slides from the staff survey. So we have data on those with a minority sexual orientation, but not good data yet on those who are trans and non-binary. And I think the other thing to remember is that this is not just a useful thing for the system, collecting data on a population level or on a service or organizational level. Collecting data or asking the questions is a way for us to demonstrate that our services are really inclusive. The example I would give that if you're a trans woman or you are non-binary and you register with a GP or you go to a hospital outpatient clinic or you check in at A&E or you're a member of staff recently employed and sent a questionnaire, your joining questionnaire from HR, if the only questions that you're asked about gender are male and female, and there isn't a box for you to tick that reflects you, that organisation or that service is already slightly, not slightly, but I would say already is excluding you, or at least not acknowledging or recognising you. So there's an individual impact of asking the questions in the same, just as much as there's a sort of a population level or organisational impact. Second thing is training and workforce development. Now, probably the single biggest thing that comes up in surveys when you ask LGBT people about what would have made your experience better, it's if the staff were trained, if they understood my experience a bit more, if they were comfortable using my pronouns, if they knew more about being LGBT or the impact on their health. So training and workforce development is really key so that all of our staff across the board are able to understand the context, understand the experience and how that impacts on inequalities, and therefore better able to target not just our resources and interventions and information, but also to just be better able to have the conversation and communicate with patients and service users in all of their diverse forms. And often that's really as simple as just challenging our default kind of a heteronormative and cisnormative culture, being more gender affirming with our language and supportive, for example, of preferred or different pronoun use. And that training needs to be across the board, both undergraduate and postgraduate level, needs to be embedded in our mandatory training, in our induction, in our continuing professional development, and needs to be delivered in a range of ways. We often rely on e-learning because it's really easy and quick. It's not always, I think, the best way to deliver slightly more in-depth or make real change to behaviour. So I think it needs to be backed up with things like face-to-face learning and training that is designed by or ideally delivered by LGBT plus people. Third area is about delivering more inclusive services. And this is one of the areas that in some ways should be relatively simple to address. And there's some things that we as individuals can do quite quickly and easily. And this is really just about, do our LGBT patients or our staff see themselves in our service? It's also about addressing often the lack of confidence or trust in the NHS as an organisation. So you need to be able to recognise yourself in a service to feel comfortable to using it. So it's about thinking about the language that we use, thinking about the imagery that we have on our websites or in our patient-facing information. Are there trans people, non-binary people, same-sex couples represented in that? Simple things like rainbow badges or rainbow lanyards are a really helpful way to communicate to people that we are an inclusive service who welcomes everyone. There's some really interesting sort of qualitative data that has come from a program called Pride in Practice, which is run by the LGBT Foundation, that go into GP surgeries and support them to be more inclusive. And feedback from the LGBT service users have said that seeing simple things like seeing a badge or a lanyard on a receptionist, seeing a poster in the waiting room for an LGBT organisation makes them feel welcome and comfortable and confident. Things that 99% of the rest of the patients probably won't even notice. But also feedback that said those simple signs improved their interaction with the doctor or the nurse, made their clinical interaction better, irrespective of what they were going in for. So we need to think about this. We can consult, we can engage, we can co-produce. We have a great resource in our LGBT networks and our LGBT staff who can support this. I'm a great advocate of LGBT networks. Frequently around the country, you see some of the biggest and most impactful changes both on staff and LGBT plus patients, coming from or being generated or delivered by the LGBT network. So they're a great resource to inform this development of more inclusive services. Which brings me on to the Rainbow Badge. I'm sure you'll be aware of the Rainbow Badge. I mean, this is a great example of a network or an individual and the network at Geysers and Thomas's just coming up with a really simple, great idea that has now gone pretty much wholesale across the whole of the NHS. I think it's now 91% of hospital trusts that have requested the toolkit, and over 75% who have actively rolled out the Rainbow Badge. And the Rainbow Badge is an opportunity for an organisation to commit to being open and inclusive, but also their individual commitments as well, NHS workers in general, whatever your role, as a symbol or a sign that we are a safe place, that people can come to us with questions. We will offer support or signpost to resources to support if we don't have the answer ourselves, and that we'll be an advocate and a support for LGBT people of all ages and their families. And as I said, they're a very simple way, a very simple symbol to break down barriers that LGBT people face when accessing healthcare. So my slight plug at the end of this is that we at NHS England, well, the NHS England LGBT health team has just invested in commissioning a pilot of phase 2 of the Rainbow Badge project. So we are really pleased to have commissioned a partnership of the LGBT Foundation, Stonewall, Switchboard, LGBT Consortium, and GLAD, which is the Association of LGBT Doctors and Dentists, to deliver and evaluate what we're calling phase 2. And this is going to bring together a focus on both patients and on the workforce. So bring together some of the experience, for example, of the LGBT Foundation's Pride in Practice project, as well as the Stonewall Diversity Champions and the Workplace Equality Standard that looks very much, the focus is very much on staff. And really what we want to do is not take anything away from Rainbow Badge 1, that still exists and that's not going to change, and that's amazing, but we want to build this into a more organisational approach, and by which we're going to work with trusts to support them to be more, address more actively the LGBT health and equalities of their patients, and develop more inclusive workplaces for their staff. And each organisation, by going through a process of working with this project, will then be awarded a gold, silver or bronze award, depending on how much they achieve. And we're kind of hoping that this is going to really play into the natural competitiveness that we, in the NHS and between NHS organisations, we often feel. So watch out for more news on this. That's going to be developing over the next few months. So this is my summary slide. I'm really feeling that I need to put the lights on. I can see the sun going down and me disappearing into darkness, although it's a slightly more flattering light. But I'll put the lights on in a minute. Sorry about that. So anyway, so this is my summary slide. So just thinking about take-home messages, solutions, but both that we as individuals can do, and also that those of us who are leaders or are, running organisations to do. So simplest thing is for an individual is to be an LGBT plus ally. You don't have to be from the community to make a change, and in fact the community can't make the change all by itself. So being an ally is often really simple, engaging with the network, supporting the network, just thinking about it, checking and challenging yourself, learning from experience. If you make a mistake, like around misgendering or using the wrong pronouns, acknowledge it, apologise for it, move on. Respect and think about and respond to the individuality and diversity of your patients, thinking about that intersectional approach. And call out and challenge poor behaviour. There's unnecessary jokes or unnecessary language, and ask the questions about LGBT equality, by which I mean challenge. Ask when you look, if someone's presenting data on equalities, ask, well, why do we not know about trans and non-binary people, or why don't we ask that question, or why isn't our language inclusive? So ask the question and encourage those who've got the power and authority to make change, to make those changes. And as leaders and as organisations, committed and visible leadership is really important. Those organisations who are doing really well on this, there's often board level support, executive support, resource networks, commitment to demonstrating that this is important and is equally important as all of our equality, diversity and inclusion work. Training is really essential, and I think all organisations, my own included, can do better at this. As I said, as an organisation, we need to be monitoring sexual orientation and gender identity and trans status for the workforce and for the patients before we're going to get really significant change, and think about how inclusive our services truly are, and engage with the networks or engage with LGBT organisations for them to check and challenge you and support you to make those changes. And on that, I will stop before I disappear completely into darkness. That's my final slide. If you are into Twitter, that's me on Twitter at Dr. Brady. So feel free to get in touch there. And if you want to get in touch with the team, ask any questions, anything we can do to help or support, anything we can do to promote things that you're doing, feel free to drop us a line. And I will stop there and try and unshare. Hold on. Screen sharing stopped. Okay, that stopped. Good. So I try to sort my lighting out while we're just gathering stuff. Not too dark. Hold on a second. Yep. You can actually see that I am wearing trousers.
Michael, thank you so much. That was a real canter through the topic in its breadth and depth of understanding. Can I start off then with a question which is in my head as a result of that, which is, and by the way, everyone else now is creating space for you to ask your questions, either in the chat or prepare to wave your hand in a moment and ask away. But Michael, my question would be, to many people, not the battle, but the challenge, but I will use the word battle, the inequality for the LGBT community may well have passed. We talk about the extremes in the 80s and 90s of HIV and AIDS, as so well displayed in It's a Sin on TV at the moment. So many people will think that moment has passed. Do you get the feeling there's a real appetite to tackle this agenda centrally? And can you tell me the sorts of conversations you have in your national role?
Yeah, I mean, I agree with you that the massive moments, which are really important in any kind of equality battle, are perhaps, and maybe that's a good thing, are not as big as they used to be. I mean, you mentioned It's a Sin. I mean, that has raised awareness about HIV incredibly powerfully. Without and I'll use an example from my work at Terror Singers Trust. We very fortuitously had a delayed HIV testing week, and I think we had like a 600% increase in orders for HIV tests around all of that focus on It's a Sin. So things like that can be momentous and move us on. I would, in terms of my general experience, I would say, and I am a very glass half full kind of person, but I think the environment in which my role dropped was an environment that was ready for it and was conducive. And it's not to say that there isn't a huge amount, and there are some really massive, significant problems, but frequently I'm putting at open doors or doors that are ajar. It's not, that there's a lot of focus and a lot of areas of best practice. And I forget sometimes when talking about all the bad things about health inequalities not to sing the praises of really amazing good practice and work that's done by NHS organisations and voluntary sector organisations. So I feel that there is a lot of hard work to do. It still feels uphill often, but I feel that there are more partners and allies in that than there were even just a few years ago. And I think, without being ambulance chasey about it, there are, the awareness that COVID has given us around equalities is an opportunity. It's shining a spotlight, reminding us of the work that we've got to do, clearly seen writ large in the terrible experience of Black, Asian and minority ethnic staff and patients. But there's a broader, greater focus on equality, which we, and I've seen things move faster because of that. So I think, and there's other pieces of work even before COVID, and before we were talking about workplace race equality standard and the workplace disability equality standard, which are useful models that we can use for to move forward the LGBT stuff. And I work a lot with very senior leaders, and I'd say not all senior leaders, but some very senior leaders across the NHS, much more important than me, who are very open to this agenda. So I feel that there's clearly a lot. I feel like I should stop talking now. I'm rambling, but I feel that there's, in a nutshell, that it's so much better than it was 5 or 10 years ago, and there are levers and partners that we can use to make significant change together.
Thank you. We mentioned before we came onto the live conversation and you mentioned it, the focus on a number of other protected characteristics for understandable reasons, perhaps the emphasis on race and disability. And we were talking earlier about the benefit of trickle down, as it were, if that's not a offensive word in any way, but the benefits that other protected characteristics would experience, including the LGBT plus community, from a focus on race and disability, which for understandable reasons, as I say, are very present at the moment. Do you think entirely just relying on that trickle down is okay for us as a community, or we need to do our own equivalent of res or WEDES to address some of the inequality issues?
Personally, I don't think the trickle down works well or enough, or certainly doesn't work fast enough. I mean, I was just thinking of an economic, a similar example. Equally, I don't believe that if you massively cut the taxes of the riches, that all the poor get more wealthy. So I think it's not to take away from things like res and WEDES, and it's certainly not to take away from the focus on, for example, ethnicity in that work or in the COVID response work. But LGBT communities, and for that you could probably put many other disadvantaged or minority groups or health inclusion groups, are so far behind and need so much of an injection or a leg up that trickle down is just not going to be enough. The changes in, or the focus in other areas certainly sets the scene, and I would say that's one of the ways that has been quite useful. So things like workplace race equality standards, or work that's going on in ethnicity, opens the door for me to bang on, or I can't bang on an open door, I'm really mixing my metaphors now, but gives me the opportunity to talk about, well, what about sexual orientation, and what about gender identity? You do know that there are LGBT BAME people as well. So the environment allows us to talk. So I think it needs all of those things. The environment or the framework has to shift, and it is shifting. We need people like me who can knock on the doors at the top and create more change there. And we still need the bottom up noise and activism and challenge and calling things out to make a kind of concerted effort, pincer movements, if you like.
Thank you. That's almost a rallying cry to the LGBT plus network to keep on with this agenda. So thank you. We have a comment from Alex. Alex, I don't want to speak for you. Would you wish to raise your query or question or your observation with Michael? I'm very happy to do it for you if you wish me to.
I'm about to say I wasn't sure if I could unmute myself or not. Really, just to say we mentioned Section 28 earlier, and there's a feeling that it's repeating itself now towards the trans community, and then something that was mentioned to me about 6 months ago is that it's strange how gender dysphoria is treated like a mental health condition at the moment, and that previously LGBT people used to be treated like they had a mental health condition. And I just thought, I hadn't thought about that before until someone mentioned it to me.
Yep. And you're far too young to recall the Section 28 era, but yes, it was sort of a pervasiveness, wasn't it? That existed in a tapping into a whole range of things, such as shame, or such as othering, or whatever. Michael, do you want to respond to perhaps the work that's going on with the trans community, and perhaps responding to that point?
Yeah, I mean, the point is really well made, and I would agree with it entirely. There are very unpleasant and unpleasant similarities between the experience of Clause 28 and the experience currently for trans people. There's an element of a state-based approach. The mainstream media. People who have authority, whether they're politicians or celebrities or people with large Twitter followers, are able to make statements which are deeply transphobic and upsetting and don't quite get as enough challenge. And my challenge, often I say this in meetings quite a lot, if you take the word trans out of that and put the word woman in there, or put the word Jew in there, or put the word black in there, and now tell me how you feel about that statement. So there is this sense of othering, and there is this sense of, in some quarters, acceptability or acceptance and a lack of challenge around that. So I completely agree with you about that. And I think that's one of the challenges, and why there's a greater need to keep talking about it, and for allies to keep challenging it. And that definitely, I mean, it's hard to imagine that fundamentally, I mean, it's difficult to say. I mean, it feels, if you spend any time on Twitter, that the world is transphobic. Actually, social-based studies and surveys it show that the population generally isn't transphobic, but people who are loud and noisy or have those platforms or use those platforms certainly are. And again, that's a similarity to well, any, I say civil rights or human rights movement, that society often moves before the politicians and the leaders do. But undoubtedly that approach, the transphobia, it does impact on healthcare. I'm not going to say it doesn't. It is difficult to explain some of the extremely poor experiences and services that are delivered for trans people without there being an element of transphobia in that. I just challenge anybody to say that. You can't. Why? It just beggars belief that people don't make as much. Don't always make as much noise or make as much change as fast as they should do, because it affects trans people. And anyway, that's that. So, but again, so one of the things, I mean, I would say, going back to that sort of diversity within the LGBT, the trans and non-binary people, need more time and more focus, certainly, of the work that I do. So they're a group where I probably do a lot of, or the most work in, and areas of focus. The data collection, monitoring is really key. The training is really important. I mean, I genuinely believe that the vast majority of NHS staff are not transphobic or LGBT phobic, but there is an uncomfort, a discomfort. People struggle with pronouns, and I think relatively simply can be supported to deliver much more gender affirming and much more inclusive care. So the training and stuff, the data collection, the training with a particular focus on trans. I know a specific area of work that I'm doing is about developing some guidelines for primary care. So I think setting aside gender identity services, the experience in general practice of trans and non-binary people is appalling as well. There's again, I need to always qualify everything. There are great GPs out there, and it's true. There are really good GPs, but across the board, it's quite poor. So we're going to do quite a bit of a focus of work about primary care, but I feel like I've rambled a little bit there, but I hope that's some thought about what we're doing. And fundamentally, I completely agree that we need much more effort about quality for trans people in general, and definitely for addressing the health of people. Can you still hear me? Have you lost me?
I think you were breaking up a bit. I don't know whether there's something you're doing at your end or our end. Was Michael breaking up for other people?
Yes.
Yeah.
And you've frozen completely. You look great, but you've frozen.
Are you? Oh, Michael, are you there?
Sorry, Michael, whether it may be that you turn your camera off for a moment and see if we pass this blip. I think Michael's going to rejoin us on a clean new connection. So other questions? Well, Michael does rejoin us and Katrina welcomes him back into the Zoom call. Other questions coming forward, other thoughts and reflections he's triggered for us? Monica and then Joan.
I'm just admitting. I was just going to ask around sexual orientation monitoring standard. The challenge is that it's not, sexual orientation monitoring is not required on the patient's spine, and that's been brought up as an issue, a barrier in our organisation for implementing it.
So we'll come back to, we'll ask Michael in a moment about whether there's any developments nationally on that agenda. Welcome back, Michael. I'll just ask for another question and then we'll hand over to you in a moment. Joan.
Yeah, just I really enjoyed that presentation, Michael. Thank you so much. I was struck by when you mentioned the importance and value of symbols and signs. And the one thing that popped into my mind was that we have a division that we call Women and Children's Services. And I just wondered, have other organisations changed the name of similar, it was Women and Children's Hospitals, and we've got a Women and Children. And I wonder what the most inclusive way of referring to that division and the work that they do might be.
So Michael, we're all holding our breath and you're going to unmute and your voice is going to be back with us.
Sorry, there we go. Sorry, this happened to me earlier. I'm on my phone now. Can you hear me now?
Perfectly.
Okay, that's a really good question. I don't know of anywhere that's changed the name of its Women's and Children's Hospital or its Women and Children's Directorate or its Women and Children's Service, but there are moves to make language in frequently very cis female focused services more inclusive, like maternity services. So I'm going to struggle to remember the exact turn of phrase, but there's some really great work, gender inclusive work that's being done by a group of midwives at Brighton and Sussex University Hospitals, and you might have seen it. There's always some degree of furore about this stuff in the Daily Mail and the Sunday Times. They've come out with some really amazing gender inclusive guidance and information around their maternity services, which I think talks about women and other people who give birth, or women and other parents. I need to check on it, but you can find it on their website. It's a real example of how to do it. So because the challenge in this area is that there are many who will feel that by making the language gender neutral, you are in some way taking away from the rights or erasing the rights of cis women, which anyway, but the language that they've used is expanding rather than retracting. It's women plus. So, and I think it's really important. It's cervical screening services for people with cervixes, not for women, because it is and it's one of the reasons why trans, non-binary, and other LGBT women don't go to things like cervical screening as much. Sorry, my Wi-Fi has just come back on again, so my other thing kicked in. Sorry, anyway, what I was saying was that, for example, a colleague of mine who's the trans rep on the LGBT network at NHS England tweeted just today, he's a trans man who'd received an invitation for a smear that referred to us ladies. It's terrible. I mean, mean, I don't have a cervix, so I don't know what it's like, but I do smears, and I know it's not a pleasant experience, but that's making it even worse from the outset. So that is a really good example, thinking about how we make that language more inclusive, because it is excluding to have a service that's called a women's service when it's actually delivering services to a range of people who need gynecological and maternity services.
Michael, before you left us as a Dalek and then returned as a human, Monica was asking about sexual orientation monitoring and the fact that it isn't currently mandated. Did you have a view on that, or is there a perspective nationally?
Yeah, I mean, I would like it to be mandated, because it would just make my life easier, and I get it. And actually, a year or so ago, we did a survey of hospital trusts asking about who had implemented sexual orientation monitoring, and if they had, how they did it, and if they hadn't, what were the barriers or blocks. And it not being mandated was one of the major reasons why it hadn't happened. So I do think, actually, if we're going to be serious about it, we do need to mandate it and think about the levers in terms of how we do that contractually, and looking in how we need to support the organisation, support the system to do that with better IT infrastructure and maybe even funds to make that happen. There is I live in a world of acronyms. There is something called the UISPC project, the United Information Standard for Protected Characteristics, which is a piece of work that's been looking at whether and if and how we should ask questions about all 9 protected characteristics. And that report has not been released yet, but it's moving towards recommending, not just for sexual orientation and gender identity, that if we're serious about it, we should mandate it, because otherwise it doesn't really happen. So I'm working on that, is the shorter answer.
There's a related question that's just come in about, as a radiographer, since 2019, we've had to adapt and ask people about their pregnancy status. Is there a national mandate on ways forward with this? As I know, the rollout of this has been varying. We've thought some in a similar vein, isn't it? Of use of language, of how we communicate, how we are inclusive.
I think the specialities like radiography, I mean, they highlight a number of issues. So one of them is about language. I mean, I don't think we'll get to a nationally mandated way to use language, but I would like to see, when guidance does come out, it's talking in an inclusive way. I mean, clearly, obviously, and radiology and the potential dangers within that, also highlight the challenges for trans people when they change their biological markers or their sex on IT systems, because obviously you need to know if someone has a uterus and is at risk of pregnancy if you're about to shine an X-ray on them. So there are a number of sort of infrastructural challenges, which frequently people find their own solutions to, or workarounds, as I'm sure the questioner has done. But so I don't think. So what's the question? So nationally mandated language, no. But I think what we certainly need to do is make use the national levers to make IT systems much more responsive for trans people, so that appropriate information about gender and biological sex where it's needed is communicated properly.
Thank you, Michael. With the last couple of minutes, I wonder if we could return to our subject of LGBT History Month and the focus on history's lives and experiences. And I wonder, Michael, whether we can end, this might be a really hard question, or someone may come to your mind, but I wonder if we could end with people or stories that have inspired you to do what you do in the way that you do it, clearly with very much great passion, and taking on a national role. So are there people from the LGBT plus community or wider who've inspired you to do what you do?
I would say I don't have an individual or famous icon, but I would say it's the patients that I've looked after in as an HIV physician, frequently gay men, but trans women, trans men, but also people from other disadvantages or marginalised groups. HIV, I don't need to tell you, by its very nature, affects marginalised, disadvantaged groups. So pretty much all of our patients, come from a position of inequality, and so one of the main reasons why I love doing HIV is it's one of those specialities where you get a really long relationship with your patients. I've been in it long enough to be looking after some people for over 20 years now, and that's a real honor and a real privilege, and I've learned so much from them. So my answer to that question is, I think it's a composite of the patients that I look after in HIV, and it was a natural progression to move from working in a one-to-one level with people who experience disadvantage and inequality to actually doing something on a national level, and frequently in meetings and when I'm doing things, individuals or individual voices of people that people that I've cared for over the years will come into my head, or I'm caring for now. So they're, I would say, my major influence.
Great. Thank you so much, Michael. We really appreciate you spending an hour with us this evening and for preparing and joining us and being quite so cool as the technology went a bit awry. So thank you for doing that. We're grateful for us. Well, I'm very grateful for you reminding us of the importance of this agenda. The moment remains. It is an important part of the diversity agenda, and you've brought that to life with the data you've shown us this evening. I personally am shamed I'm not wearing my rainbow badge. I was rooting around just to try and find where it is on my other lanyard. I'm going to get it out with increased pride. And no doubt Monica, I can see, is making notes about the rainbow badge too. We will be there. We will be amongst those organisations because of the agenda you talked about so clearly and wisely to us. So unless there's any other points of observation, Michael, thank you so much for this evening. We really appreciate it. There's a network meeting, I think, next week. Monica, am I making it up? There is one coming up, which will circulate the date. This will give us renewed energy and focus, as will the whole of the History Month. Alice is going to tell us exactly when it is.
I believe the next LGBT plus staff network is actually tomorrow, midday at 1.
Brilliant. Tomorrow. Perfect timing. The energy will remain with us for tomorrow's meeting. So thank you all so much, people from the network, friends of the network, people who are passionate about this topic. It's great you've joined us this evening, and I look forward to continuing that journey with you all. So good night, have a good evening, and I think we show appreciation on mute, Michael, but thank you so much.